Yeah, really grateful to our speakers this afternoon who have taken out so much time from their busy schedules to join us. And we really appreciate that. So with us today, Dr. Liew, consultant cardiologist at Queen 2, Mr. Daron, chairman of IDRN Asia, as well as Dr. Amar Singh, who has become quite well known in Malaysia during these times. So we really appreciate all of them for joining us. To start us off today, I would like to invite David Houng, president of the Sabah Disaster Preparedness Association, to welcome us. Over to you, David.
Right. Thank you, Eric. A very good afternoon to all of you. Firstly, on behalf of the organizing committee, I wish to thank you all for taking time out of your busy schedule to join this webinar organized by SDPA in partnership with IDRN. What is SDPA and what do we do? SDPA stands for Sabah Disaster Preparedness Association. Our vision is to help raise the awareness of community preparedness to emergency, crisis, or even a disaster. Can be a flash flood, can be a fire, can be an earthquake, and can be a pandemic like now. So our member comprise of people who believes in the importance of being prepared. So we conduct community-based disaster preparedness training as well as response training certified by IDRN. We also organize webinar like this, we networking events and sharing of information to help our community to be more ready for a situation. So today we are very fortunate. We have three very prominent speakers who are well versed in their fields of expertise to share with us and to educate us how we can be more prepared and better cope with this COVID-19 pandemic. Very big thank you to all our speakers for kindly accepted our invitation as panel speakers. It is our honor to have you here this afternoon. So I hope this webinar will be beneficial to all the participants and help us all to become more resilient. So I can't help to hear from all our speakers. Without further ado, I'll pass the time back to our OC and MC, Eric. Thank you very much. Over to you, Eric.
Thank you so much, David, for welcoming us. And thank you for all of you who are joining. I see now that we have 142 participants. Wow, blew away our expectations, and we hope more will join in. So if you have any friends, family, people you know who have still not logged on, please ask them to connect now, and they will greatly benefit from this afternoon's talk. So not too late, please get the word out now. Not too late, not too late. All right. First up, we have Dr. Liew, consultant cardiologist at Queen Elizabeth II Hospital, who will update us on the situation in Sabah. So over to you, Dr. Liew.
Hi, hello, good afternoon. Thank you very much, Eric, for your introduction, and David, for the initiative, to organize this. Good afternoon, ladies and gentlemen. Let me share my slides and I'll get started. Okay, can you see the screen there?
Yep, can see it.
Okay, so I'm actually going to just give a brief, I'll call this as a, what I call it, an entree, for this webinar. I think the main course will be from our two eminent, speakers, Dato, Dr. Amar, and of course, Daron. So as we know, COVID-19 continues to surge worldwide. You can see that there, that, the surges come, waxes and wanes, and we are still in the midst of this surge now, especially because of the variant. And this is something we have foreseen. And people had talked about this last year, in the first year of the pandemic, that we are not going to see the end of this in short term. The COVID will continue to come back until we have a better solution in terms of treatment, and of course now the vaccines. You continue to mutate, and the variants will continue to pose challenge. Not just that, but also there's a human nature that, the fatigue that we start to see some relaxed slack prevention, not just at the individual level, but also community and even at the policy level at times. So a real reality check, for Malaysia, and this is yesterday. Everybody has seen this, of course. Yesterday we had 22,070 cases, and that brings us to a total of over 1,662,000. For Sabah, we had 4 days of over 3,000 cases, and that trend, is likely to continue. So as of yesterday, for Sabah, which I've highlighted here, we have now logged in 137,000 cases. And the numbers itself probably sometimes don't speak volume, but when we put in the context of the population that we're in, it can be very alarming. Take, for example, in Sabah for the last 4 days, that we've been seeing 3,000 at least a day. Against a population of 4 million, we are talking about an incident rate of 82 cases per 100,000 every day, average it out over these last 4 days. In Malaysia, just based on yesterday's caseload of 22,000 against a population base of 32 million, that gives about 69 cases per 100K. So you can see that Sabah actually has a worse situation compared to the rest of the country. And in terms of ranking, this is from the meter for COVID-19. And again, if we tell people they have a 3,000 case per day, it may not be as alarming. But when we put it into a certain context, that when we had Malaysia has 22,000 cases per day. That translates to about 919 new cases per hour, which is about 50 new cases per minute, which as I speak, every 4 seconds, 1 new case in Malaysia. And that brings us in the world ranking in terms of the number of new cases in 6th position. When we look at the number of daily new deaths, again, when we look at the 339 deaths, that's about 14 deaths per hour. And that's about 1 death every 4 minutes. And that brings us again in the ranking worldwide in 9th place in terms of daily new deaths. Sabah, of course, at the moment is also facing a problem with a lower vaccination percentage in the adult population. And this is something I'm sure later in our discussion we'll bring up. In terms of the total number of very sick patients that require ICU admission, these are the states which are in the phase 2. And this is just the statistics showing that trend since June up till mid-August. And you can see Sabah actually has a very high number of ICU admissions. And these analyses are based on our Ministry of Health published numbers, and this is looking at ICU. And 4 lines there. The Malaysia one is the yellow one. And then we have the Sabah, which is the blue line, which you obviously can see is on the rise. And of course, in the Klang Valley, there seems to have a subtle downtrend now. Sarawak, with a very high vaccination, seems to be able to keep it at bay. So those are the reality. Now, how about forecasts? Now, it's always, we had to be very careful with forecasting. And this is something recently shown from Ministry on the daily forecast for the rest of the year, 2021. And this is shown with a projected peak at around mid-September. Hopefully that will be the case once we have all the measures stepped up. And based on that, for Sabah, we are expecting to see until the end of the year, a total case from what I mentioned as of now, about 130 over 1,000 to 260,000, which means we expect in the next 4 months, doubling of whatever that we have now. Now, is that the case? I will show you something which I hope I'm wrong, but I think it's something which is quite alarming. I like to share. This is based on a week-to-week trend of the Sabah cases in all the districts and of course in totality. What I've shown here in the table is in the last couple of weeks up till now, the number of cases per week. And sometime in mid of July, we had about 4,497 cases per week, as you can see there, up to the latest as we are now. In this week itself, from Monday to Friday, we have about 15,000 cases. And what I have, the last column is just to show the percentage of rise compared to the preceding week. So you can see here, we have about 40% rise, 29%, and so on. Now, let's say that for the next 2 days, that today and tomorrow, we have again 3,000 cases per day, which means we'll add the 6,000. That will total for the week of 21,000. And that will give us, compared to last week, about 28% of case increase week to week basis. I'm going to show you now what, if we take a very conservative estimate, that projecting a 25% increase per week in the next few weeks, that will give us a total from 21,000 to 27,000, 33,000, and so forth. And that translates, if you divide it into 7 days, give you an average day case, the number of cases a day, which is about 3,800, followed by 4,800. And by mid-September, we could possibly hit 6,000 per day average. And to add into whatever we have now, which is 137,000, and accumulate, every week, that means that will bring us to 170, later 200, and by mid-September, 246, almost double whatever we have now. So we are in a situation where I think, it's already simmering, if not boiling, it's going to boil over even worse. This is at mid-year when we shared the natural recovery plan that we are hopeful that we can roll out the vaccination, and with all the ongoing SOP, the MCO, we are able to keep the caseload down to less than 2,000 per day. And obviously, we are nowhere near that. And we've been reminded that vaccine alone, cannot get this under control. And I think we had to be reminded that we had to continue all the SOPs, personal level of responsibilities, as well as a community level. Vaccine is only one of the slices of cheese, as we say. There are many things that look at masking, of course, social distancing, effective testing, and of course, also in terms of indoor ventilation, many slices of cheese here. But I think this is something we hope today, why we engaging community is this. Hospitals is not the front line. Hospital is the last line of defense. The front line really is now in the community, in individuals, in households, in workplace. So here my key message. COVID-19 surge is expected to worsen and probably sooner. We had to anticipate that so that we can prepare more for surge capacity. We anticipate so as to intensify our prevention. We had to anticipate so as to mitigate this crisis. What can we do? At the community level, I hope that later we have some sharing from, Dato Dr. Amar, and of course Daron, on what we could do as individual, as households and workplace. I think the key strategy is going to look at this from both ends. The upstream end is the vaccination. We cannot, reduce the absolute number of cases, but at least we can reduce the severity, like what have been seen in Sarawak. Very important as well. The other thing is, of course, our environment. And I think this is where we have to look at new norms, including our ventilation and so on. So I'm going to end there. So hopefully we can hear from the other two speakers and have a good discussion after this. Thank you very much for the time.
Thank you so much, Dr. Liew, for sharing with us. Really appreciate your insights and updating us on the situation in Sabah. We now have 234 participants here on Zoom, and we also have people live on, we just hit 233. Still not too late to get the word out. Please take this time to share the link with your friends, family, community, and get the word out for those who can't join us on Zoom. I have posted the FB Live link in the chat as well, so they can join us through that as well. So our next speaker is Dato Dr. Amar Singh, and we really appreciate him taking time out from his busy schedule to help to speak to us today. So over to you, sir.
Thank you very much, Eric, and thank you to David and Kenneth, who's working in the background to help us. I enjoyed listening to Dr. Liew and set the stage for us. And Daron, thank you for the one who's organized to invite me here. Daron and I did one for Sarawak a couple of months back. The same day started Preparedness because Sarawak was in a bad shape earlier in the year. Please call me Amar. Anybody who calls me Dato or Doctor will be fine, 50 or 100 ringgit, and we'll give it to the disaster organization for support work. Okay, just call me Amar, is fine. I'm going to share some slides so we can get on with this. Can you see the slides, someone?
Yeah.
Yeah, thank you. This is a graphic drawn by Samsia Hassani, who's an Afghanistani first female street artist and just had to be evacuated from Afghanistan. But it shows the kind of feeling all of us have. I've just posted a link inside the chat. This link gives you a couple of documents may be useful to you. You can also scan the QR code to gain access to the documents. Some of them are MOH clinical guidelines, which I think you should have. We get a lot of questions about, you know, I've got this disease, can I get vaccinated, pregnancy and stuff like that, and home care guidelines, which are useful. I've also got a US home care guidelines there. I've written some other documents, some I've updated. 1, 2, and 4 are going to be useful for today. Number 1, especially the suggestions for supporting the community, and the health emergency action plan is a roadmap to recovery. Number 4 is primarily for yourself to keep yourself safe. And of course, if you're interested in children vaccination, there's a fact sheet there. I'm going to cover a little bit about the situation in Malaysia as a whole, give you some overview, and I'm also going to come back to Sabah and focus you in some areas. Then I'm going to talk about some current concerns about Delta and do vaccines work, then what we can do personally and what we can do as a community. All right, let's plunge in first to what's happening in the country. Now, we all know this curve, whether we are in the 4th or 5th wave or whatever wave, it doesn't really matter. We are in a mess, okay? You know, it took 1 year to us to get 100,000. Now it takes less than 1 week to get 100,000 cases reported. So we're growing very, very fast a day. And if you look at the data as a whole, I think we cannot look at data as a whole anymore because here's Klang Valley data as vaccination, whole country data as vaccination goes up, thing comes down because Klang Valley is improving as a whole. So we need to track state and district data now. I don't think we've come down to district data yet, but state data we can start to give you. Okay, so in August, early August, I wrote this article and I state what's going to happen to different states. And I talked about how Sabah, Kedah, Perak, Johor, Penang, and now of course Kelantan is added to this, are deteriorating rapidly because of our low vaccination rate, Delta spreading rapidly, and our infrastructure is weak in some of our states. I think most of our states is weak. So we are going to become worse than Klang Valley. And we're just starting for that to happen to us right now. So here's COVID cases of the 6 states that I'm talking about. And this is the ones that I'm pushing the government and the new Minister of Health to look at as well. They're all on a rising trend. Notice that the y-axis is different for each of them. So Sabah is probably the largest of the lot right now, but Kedah is in bad shape as well. Okay, Perak also, I'll talk a bit more about this in a moment. So what we need, besides the case numbers that they show to us every day, is the testing numbers and the test positivity. But they rarely show this for the state. They show it for the whole country. And the blue lines are the daily tests. The red line is the test positivity rate, which is on the axis on the right here. And you can see the WHO says less than 5%, please. But you can see for since July all the way to August, we've been above that, and we are actually climbing, getting worse, hitting 14, 15% test positivity every day. What does it mean? We're not testing enough. That means that pandemic is probably 2 to 4 times the size that we are seeing. So if they quote you 22,000, you multiply by 4. That's what you should do. Minimum multiply by 2, but probably multiply by 4. Just today, we managed to get state testing data. First time I've seen it in a very, very long time. And look at Sabah's test positivity. Sabah's test positivity on the 26th of August was 27%. That means for every 4 people you test, 1 is positive. That is horrendous. That means your epidemic, your outbreak is underestimated even more. You probably need to multiply by a bigger factor in Sarawak than the rest of the country. But notice Perlis, Kedah, Kelantan, Selangor, Kedah also doing very poorly compared to the rest of the country. So stop looking just at case numbers, push for test positivity. You got a different kind of government than the one I have in my state, in Perak. You can probably push them to give you this every day as a monitor of what's happening. We are not testing enough, and Sabah is definitely not testing enough at all. Okay. Also, the other problem, we need current data, and here's data from 26 again from Sabah. And notice that of the 3,000 plus that were reported in that day, quite a number were more than 5 days old. Some were 4 to 5 days old, and a lot were 2 or 3 days old. So you're not seeing today's reports. You're seeing old data, which is not good, which means it's taking time for the data to come in to the system. So it could be a lot worse already now. We don't know because the numbers are not being fed to us. Partly this is using the PCR test. We're again pushing when your epidemic is bad, just go straight to rapid antigen RTK test because it's going to give you an answer quicker. Notice also for that day, 27% of your cases were children, which is a worrying trend for Sabah. So what data do we need to monitor the pandemic? I'm saying this to you because I think you should push your administration to get this. Cases, as I said, affected by test positivity and miss many. Hospitalization, only valuable if you still got beds. Once you run out of beds, then there are people sitting in emergency department and quarantine centers, and we are starting to see this in our 6 states. So then hospitalization doesn't become so valuable. ICU beds only useful if you still got beds. Once you go past your full number, then people are ventilated and casualty all over the place. They don't count those at all. That's why the national ICU beds never really go up every day. And finally, deaths is the most reliable, but they are reported late. And so they are a late indicator of the outbreak because they require 2-3 weeks after the cases for the deaths to appear. All right. So let's look at Sabah, what's happening right now. The orange bars there are your cases. The black line is the 7-day average of your hospitalization. And you can see your cases have exceeded that horrible time you had last year. And now even the hospitalization has gone past that. In fact, I would say you can stop looking at hospitalization right now, numbers, because you've gone past the thing. Many patients are already spilled over into your casualties and being managed there. So that metric is no longer valuable. The case numbers, again, because so many are not being tested, also a limited metric for you to use. Okay. So what about ICU? Here's ICUs for 26 August for a couple of the states. I have a lot of question marks there. Why? Because I don't think this data is complete. I watch this data many times, a couple of times a week I go and look at this data. And you can see the official data in Perak quoted by Ministry of Health is 103. The data quoted by the State Department is 134. So for Perak, for example, okay. So I don't think this is correct. A lot more people are ventilated than the ones quoted here. Can I give you an example from Perak? I was looking at data recently from Perak, and for every 4 persons who need an ICU bed, only 1 gets it. Can you imagine that? This is the same situation we have in Klang Valley. Huh? And what do I mean by ICU bed? Need ICU bed? You're in category 4 or 5. There are 5 categories for COVID. When you're category 5, you need to be ventilated. 4, you're very ill, you need oxygen, you should be in ICU bed. So for the total number in Perak who are in category 4 and 5, of every 4 people like that, only 1 of them can get an ICU bed. I wouldn't be surprised if Sabah is in a similar situation than that. And that's the kind of data we are looking for. Here's looking at deaths for our 6 states. And you can see this 7-day average of deaths, because deaths are smaller numbers. I use 7-day average. You can see the deaths are generally climbing, and your deaths are actually climbing very, very fast. Yesterday's deaths were very alarming. Last couple of days for Sabah, very alarming. Here's Sabah deaths from yesterday, 41 deaths. And notice the brought-in date was 17. That means 42% of all the people who died in Sabah yesterday were brought in date. Again, we hope this is the 41 from yesterday. I suspect the deaths are also delayed by a couple of days. So we are seeing delayed data there. But I want you to think of this brought-in date. When you have a large number of brought-in date, it means your community health system is failing. We're not identifying these people, or they're sitting at home waiting to be called, or they're not tested, and they don't have any oxygen monitor that Daron is going to talk about later. And we need to provide them support because this is the rising number. Quite a number of the deaths actually in the Klang Valley were migrant workers, and you may also have stateless people who also fall into this category. I'm not going to show any more comparison with other parts of the world, but I thought I'd show you deaths compared to other parts of the world, and you can see we are climbing. whereas other countries are not doing so well. You can see here, Thailand is coming down, US, of course, growing in this time, and UK growing slowly. So we're not doing well compared to the rest of the world. Bloomberg has rated us the worst out of 53 countries in terms of preparedness. I'm carrying on with that a little bit. Houng talked about the latest August data, but I've merged all of the August together, and it's 9.3, 9.9, almost 10 deaths per hour right now. But you can see the change over time that's happening in the country. And this is the brought-in date figure for the country. And you can see again this trend that's going up. But I suggest that you plot this trend for Sabah, watch your brought-in date rate every day and see the trend and see whether it's going up. And that will tell you whether the system is coping or failing. So the data you should ask from your State Department, please tell us category 3 to 5 and deaths every day by location. Where are they? You don't have 3, it doesn't matter. 4 and 5 is fine. You want to know when the category 4, category 5, and the deaths occur. Are they sitting at home? Are they sitting in the ICU? Are they in a general ward? Are they in a casualty? Are they in a quarantine center? If they are not in the ICU, they are in the wrong place. I would like people to die in the ICU, which means they reach the right level of care. And you need this by your whole state, plus you need it for different districts. I also want to point out that there are collateral deaths, and we have no data on this. Collateral deaths are people who couldn't get in the ICU because COVID patients fill the ICU. And finally, of course, you need vaccination data by granular variables. We need to know those who died by their vaccination status as well. Okay. So what are our current concerns looking at what's happening in Delta? We know Delta is spreading. We do very little genome testing in Malaysia, and we need to push our new health minister to grow this. I think only Sarawak Unimas is doing a large number. And Delta, we know, compared to original virus from Wuhan, Delta is a lot more infective. It spreads a lot easier to people. And of course, we worry about Lambda coming in the background. And Delta also seems to cause a worse outcome. Most people are quoting a 2 times worse outcome than the original or even the Alpha strain. And here's a 19-year-old, Houng can show you many pictures like this. Liew can show you many pictures. It's a complete whiteout of his lung, and he's only 29 years old. The one on the right is normal. And this disease is not just a respiratory disease, it's a vascular disease. It's damaging his heart, it's damaging the vessels in his lung, it's damaging the vessels elsewhere in his body. And this young man died, and we're seeing a lot of young people dying recently. Okay. So currently, we've lost data after this period because MOH doesn't share it anymore to us. We know there's slight preponderance of men because men are weaker than women. We know that about 20% have no comorbidities, have no chronic illness. We know that 30–40% are under 60, the younger people. And we know that almost 70% of all our deaths occurred just in June and July. But I think August is going to beat this. I also want to point you out that 1 in 10 people who leave the ICU die after they leave the ICU. This data, again, is not data that the MOH shares with us, but from a large BMJ study in the UK, they show that 1 in 10 of their patients that they discharged from the ICU died later. So the COVID deaths linger on even after their discharge. So what about Delta and vaccination? I get asked a lot of questions. I thought better we'll deal with this. 1 dose of Pfizer or AstraZeneca is not enough. And from CDC and the UK recent data in Lancet, 2 times more severe in terms of hospitalization. It can prevent a lot of severe illness, but breakthrough infections may occur, as Houng said just now. So basically, the figures that most of us are receiving from CDC, you can reduce your severe disease or death by 10 times by vaccination, and you reduce your risk of infection by 3 times. So you can get infected, but you really reduce your risk of dying or getting hospitalized. Okay, so universal mask after vaccination is critical, and higher risk people and the one with comorbidities are the one who are probably going to get into trouble even after vaccination. So I want to stress this point: even after you're vaccinated, don't let down your guard. Now, a lot of people have been posting this image showing what's happening in Israel here on the left and UK on the right with Delta. And despite the high rate of vaccination in Israel, the hospital admission going up, whereas in UK, it doesn't seem to have gone up yet. But can I say that data requires thinking? And sometimes it's just too simple to show this. Has been a very, very good analysis of the Israeli data There's a link down here for this guy, and he talks about a Simpson paradox, which Houng will know very well from our research data. And if you break up the data by under 50 and above 50, then you see the protection is very good. It's a paradox. Huh? Notice when you put it together, the protection goes down. When you break it apart, the protection looks much better. So I want to say this one message, even from Israel, whatever the WhatsApp messages are telling you, the scientists looking hard at data, whether when you're vaccinated, your protection from getting hospitalization is very good from the vaccination. So you need the vaccination to get this kind of protectivity. What about Sarawak? No, Sarawak, I watch data very closely because Sarawak is a Sinovac incubator, and some of us have got Sinovac vaccine. 80%, 79, 80% of all the vaccination in Sarawak were 2-dose Sinovac. And here's looking at the data. The blue line is the new cases, and you can see it's creeping up. We don't worry about cases anymore in Sarawak because just because you are vaccinated doesn't mean you cannot become infected. You can, but we worry about the red line, which is the hospitalization. And you can see that's starting to creep up. Again, now what we need to know is how many of these are vaccinated. So we can break down data and come to this kind of Israeli data and give you an idea how effective is Sinovac in hospitalization. We don't have an answer yet because people keep asking us an answer, but we don't have good data on this. But notice that even in a very, very good vaccinated area, the health system can still be stretched. And here's looking at the ICU beds in Sarawak, just looking at August alone, and you can see it's going up. So as long as the pandemic grows and grows, despite vaccination, we still need support from the community because the health system may be overrun. So summarizing Delta and variant, I want to say that just because you got no symptoms doesn't mean you cannot spread virus. Just because you're vaccinated doesn't mean you can't transmit. You are blunted, you definitely won't likely, many of you won't transmit, some of you can transmit. We must treat the vaccinated like the unvaccinated. I don't like vaccine privileges at all. Same SOPs as far as I'm concerned. Even though I'm fully vaccinated, I behave the same way. Okay, and the behavior change of the vaccinated is what I worry about. Some of them become very relaxed. I get messages from my friends saying, my mother-in-law now happy to go to the supermarket. I think, please teach people that this is not a safe behavior to change at this point until more people get vaccinated. Now I'm going to talk a bit about vaccination, and we know our vaccination in the country is ramping up, but I'm more interested in the individual vaccination that's going on. And you can see these states that we talked about are very poor because they push vaccine to Sarawak and the Klang Valley. And so we are in trouble. I look at total population vaccination rates. I don't look at individual, I don't look at adult vaccination rates because total population vaccination rates are more important. So why are we poor? We are poor because our supply is poor. And Sabah has got the poorest supply. I don't like this. It's unacceptable. Vaccine equity is important, and I think we should appeal and advocate with our new health minister that we should push vaccines to these areas which are struggling, especially Sabah, because Sabah is actually the worst of the 6 states right now. Okay, so here's your vaccination total. Again, I count total. I don't count adults, and you can see this going up. And if you project that, this is what's going to happen to you. You're going to get, now I'm going to adult, the target that you're aiming for, 80% adult by the first week of October. Don't forget, you need another 2 weeks for kick-in effect. So somewhere in the middle of October, you're going to reach the kind of place you want to be reaching. That means you've got 8 weeks of struggle right now, friends. That's what Liew was showing you earlier from the rise and rise and rise. So for the next 8 weeks, we're going to see a steady rise, maybe then a blunt and then go down. I don't think our peak will be mid-September. It's probably late September or early October when our peak and then come down. And I'm no different here. I'm in Perak. We got the same graph that you got. And at the current vaccination rates, we're going to hit the same situation that you're going to hit. We're going to struggle for the next 6 to 8 weeks badly. Okay. What can we do? There are 3 things that you need to think about right now. These are the 3 realities, okay? I now come to believe everybody is going to be exposed to COVID, and perhaps everybody get infected in some form. Huh? So what you should aim one is reduce your viral load. How do you do that? You wear a good mask. I'll talk a bit more about it. Wear a face shield. Limit your exposure. Don't take risk. Cut down your exposure to other people. Second, reduce your severity. How do that? Get a vaccination the moment it's available to you. Maintain your fitness. Avoid overweight. And thirdly, reduce community spread. How you do that? We push for contact tracing, testing as many people as possible who are the contacts, and we improve ventilation, which I'll talk a bit more about. Okay. So the things you can do are these 8 things. And I'm not going to cover all of them. I've got a document inside there, but you limit unnecessary contact, you work from home, online education, mask, quality, vaccinate, ventilation, personal fitness, support others. Let me cover one or two of this. I want to say there's no safe number. If somebody says 5 people can meet, I don't believe that. So don't believe that, oh, you know, why that group, religious group can open, why my religious group cannot open. Just be thankful your religious group cannot open. Okay, thankful that if the churches or the mosque or the temple says don't open, there's no safe number. So you got to maintain what I call a home safety bubble. You need to keep your family safe. Some of you need to go out, you know, and maybe buy food or work or something, and you need to maintain your safety so you don't infect your home. The work safety bubbles are toughest, and I think, you know, you need trust bubbles, what I call. That means everybody at work must be able to trust each other. One way we can do that is routine weekly rapid antigen tests. And I think we need to lobby very strongly for the price to come down, because the price can come down to 5 or 10 Malaysian ringgit for this test. And if everybody can get one test a week, in UK, they've been testing twice a week for months, for more than 9-10 months. But if you can do one a week of your staff, then I think you can dramatically reduce your risk. Okay. Some other important issues. Don't eat lunch together at work. That's when you unmask. Never eat lunch outside. That's why I haven't been in a restaurant for a year and a half at all. You know, bring a packed lunch in a quiet space without other people, outdoors preferably. Don't unmask a toilet. Toilet is a very dangerous place at work. And if you're transporting migrants or other people in the bus, that's a very high risk transport. I also want to talk about this fan. This is a ventilation fan. It's called the Corsi Cube. Very easy to get information about it. You know, a couple of 100 ringgit, you can put it together. It's a DIY fan. This is the best fan right now, the best, cheapest fan to actually ventilate a room. It sucks in all the viral particles and actually offers you a gas exchange, very high level gas exchange produced by this guy called Corsi. Okay. For children, I still think we shouldn't go back to school just yet. I think it's preemptive, and I will push online classes, but we need to think about our poor children who don't have access and push devices to them. Now for masks, please improve your mask. I see a lot of people still wearing a single mask. I would wear a double mask outside, a 3-ply cloth mask, inside a surgical mask, or I would not intact. I think this is not as good a 3-ply one. Here's me. This is what I look like after 2-dose vaccination. I got an N94 Korean mask. Why did I buy this one? Because the fit is superb. The filtration is excellent. The breathability is great, and I can reuse it. They say can use 10 times. I use 5 times. You spray alcohol on it after you use and air dry it for the next day. And I have a good face shield. I have many face shields, different type of face shields. I invest in many different kinds of masks. Okay, because this is a very, very important thing. My highest risk things, I go out and buy lunch. Even then, I buy from the coffee shop at the edge. I never walk inside the shop. Even then, I'm like this for this. Why do I wear a cap? I don't want a draft to come down the top into the top of the face shield. Okay, so don't put all your eggs in the vaccination basket, please. Now, for those of you who are worried about vaccination, a lot of rumors, WhatsApp group, you know, every day almost I get a video or a message. Please look at this one. You think it's true or not on some issue of some conspiracy theory somewhere. Now, this is the big picture. This small dot here on the left is the vaccine side effect we're going to experience. The dot is too big, by the way. I can't get any smaller on PowerPoint. That's the size of vaccine. Are there going to be vaccine side effects? Yes. Are some people going to get damaged? Yes. Maybe occasional people die. Yes, I cannot lie to you. This is going to happen with vaccination, but it's very tiny. But this is the deaths from COVID. And this is in the best of times when MOH had all the ICU beds last year. Can you imagine the deaths right now? This dot is growing bigger. This is long COVID. People who struggle and suffer after having COVID. Even some of those who don't end up ICU have long COVID. They can't think straight. They can't go back to work. They can't walk across the room. Their lungs are damaged. This lasts, you know, sometimes 9 months or 10 months. Some people don't recover. And that's collateral deaths. People who die because they couldn't get an ICU bed or commit suicide because of economic reasons. And largely, this big gray one is how your and my life has been damaged completely. And that's too small. Actually, you should fill the whole circle, whole square, isn't it? We're completely wiped out. So think of the big picture with vaccination. Yes, there's a possibility that I may get damaged. But, you know, if you get any one of these other things, long COVID, collateral deaths, or deaths due to COVID, it's going to be a lot worse. Now, ventilation is the underspoken about thing. You know, I'm going to talk to the health minister, and what I'm going to say to him is 3 words: ventilation, ventilation, ventilation. You know, we must think of it as airborne, indoors. 1 to 2 meters indoors is of little value. So we must improve ventilation. How do we do this? Stop your aircon recirculating. So if you cannot stop that, you've got to turn off your aircon, open your windows and doors, and then watch how the draft is. You don't want the draft moving from one person to another person in the room, transmitting the virus, okay? You want a stand fan at the window to suck air out, an outward facing fan. If you've got a toilet, put an exhaust fan and suck air out. And, think of the Corsi fan I showed you earlier to stick in this room. I think every classroom should have a Corsi fan. And every classroom should be open air. If you are an international school, I would turn off the aircon, open all the windows and doors right now and not use the air conditioning at present moment. Long term, we could think about HEPA filters and UVC and stuff like that. Okay. How can the community help? I've got 3 messages for us in the community. You can never prepare enough for Delta. Once you think you prepared, then you prepare some more. Even then, there will be heartache and anguish because Delta is going to overrun you in the next 6 to 8 weeks. Don't put all your eggs in the vaccine basket. Use every single tool you have. Don't just wait for the vaccination to ramp up. Some state governments are doing this, and this is dangerous. We're in this together, and so we need an all-of-coordinated society approach, which is why we're all here together. With some friends, I wrote a health emergency action plan that's available to you. I think we should push our state to tell the truth. We should, push for strong leadership at all levels right now. And as I said, we should, push for other tools like rapid antigen kits. I'm going fast here for certain reasons. Also, I want to say, think about the large PPVs. I'm not so happy with them. A lot of people meeting together in a large place. Not everybody's mask is equally good. I think we should push back to general practitioners, health centers, school health teams giving the vaccination in smaller places where we can actually control the ventilation and the risk of exposure. Okay, so I think this meeting is about coordination, and I think we must coordinate as NGOs to meet needs. Daron will talk more about it, but I think that what I've been asking many people to do, and I want to ask you also to consider, please consider purchasing and donating equipment. You can donate to 2 places. You can donate to hospitals, or you can donate to disaster groups and they can use it. And there's a whole bunch of equipment that I put up a list for. Some hospital staff and some disaster people also need protective equipment. We also mustn't forget that if we can make more testing kits available and buy them and make them cheaply available to people, then actually maybe more people can protect themselves by testing themselves. Okay. Oxygen concentrators are very valuable, more valuable than oxygen tank because they don't require refilling. Okay. I actually think we need this. We need to grow ICU tank. I talked about this last year. Early last year, I talked about it, but didn't listen. I talked about it a couple more times. MOH is not talking about this. We need to push. What minimum you can do is talk to the army. If you have no contact, I know the army. I know the Brigadier General who's my house officer. He's a nice man, okay? And he can bring a field hospital. So maybe for Sabah right now, you should push for ICU and field hospitals next to KK, to Sandakan, Tawau, places that you need them. Okay, you need to prioritize where you want them, and they can dismantle from other places we don't need them and bring them over to you. Secondly, I think home monitoring, and I hope Daron will talk more, and we must think of how to support people in home monitoring. I'm not going to go through all this, but I want to say that one thing you should consider, there are a lot of people who are poor, there are a lot of people who are migrant, stateless. You need quarantine facilities. I like what CREST has done. CREST has started up a purpose-run hotel. They took over a hotel, got funding from a corporate body, and of course, turned off the central aircon. And now they house migrant workers as well as the poor who have no place to go to have a safe place to quarantine. And of course, they monitor them closely there with doctors, okay, using a finger pulse oximeter. I think every home should have a finger pulse oximeter at this time, a reliable one, mind you, not any old one, okay? There are also communities hard hit. And as the pandemic grows, I think we're going to start thinking about food delivery. And I hope there are NGOs among you who are thinking about food delivery. And finally, don't forget that there are people who will need support for emotional trauma. I put together a group for the Klang Valley for children who became temporary or permanent orphans. This is all the child NGOs that I'm working with, but we have now been able to extend to other states as well. So if you have orphans and need support, please let us know, and we actually can extend support to orphans elsewhere. I'm sorry to rush through the last bit, but I wanted to give Daron a chance to talk, and then we get questions. And this is I hardly do selfies. I never do selfies actually, but the selfie I took this morning, purposely for you guys. This is from the roof of my house. We have a ladder going up, and I watch sunrises all the time. We need to keep our spirits up. If you don't invest in yourself, you cannot help other people. So every day I spend time alone with God, alone with my wife to hang out with her, have breakfast on the roof, watching the stars, and then I watch sunrises. And I also have a 30-minute physical workout. You need to keep yourself fit. Don't try and help other people if you yourself are not looking after yourself. So watch the sunrise, spend time with God, and keep your fitness as we try and extend care to the community. Back to you, Eric.
Thank you so much, Amar, for sharing with us. Wow, huge amounts of information that we need to digest, and very relevant facts and information. For those of you who joined us, Dr. Amar has kindly shared with us the link for Google Drive, where you can download some of the information that he's talked about. So thank you for that, Amar.
I posted it again, Eric, just in case. Sometimes people come late, can't see the link. So I posted it one more time. Okay.
So it's there if you need to download. Okay, for questions, because wow, we have 400 participants, so it will be a bit chaotic if everybody starts speaking at the same time. So what we're going to do now is, if you have any relevant questions, I know there are probably 1,000,001 things that you probably want to ask, but let's try to keep it relevant so that we can try to address the pertinent questions. So
Eric, what about Daron?
Yes, I'll pass to Daron in a sec. So if you have any questions, please post into the chat group. And we will forward that to Daron and Amar, and we will try to get to you. All right. So any questions, please post in the chat group. And Amar has also posted a link where you can download some of the resources that he's talked about. So now I'd like to invite Daron Tan, Chairman of IDRN Asia, or International Disaster Response Network, to share with us. Over to you, Daron.
Thank you, Eric, and thank you, SDPA, for inviting us this afternoon. I think for many of us monitoring daily the situation in our country, we are concerned about what is developing. And of course, the main thing is what can we as community do in mitigating this crisis. So we had a very good sharing by Dr. Liew and Dr. Amar, and I hope that will ring an alarm bell for each and every one of us here, particularly community leaders. One of the things that we always shoot for with IDRN is we try to engage community leaders and also individuals who are working with small groups, maybe not large organization, but you have networks and you want to do something for the community. So we always welcome that kind of participation and engagement. So there are three things I want to share briefly this afternoon, because I think we had a lot of information, and this information is useful for us to process our approach to dealing with some of these problems. And these problems are common all over the nation. So the first thing I want to share is never underestimate how crucial and how important community's role is. And I would say this to leading agencies and organizations involved in this particular crisis, that don't downplay the role of community. I remember years ago, Gustavo Lara, the Secretary General of Red Cross Dominican Republic, he says we are living in these days when the public no longer are passive players in crises and disasters. And social media and news get to them, and they are the ones on ground zero and on location, and they have large vested interests. So I would say that to many of us, we are in the community, we have large vested interests in whatever that's developing in this nation. So one thing that I would recommend is that the suggestions that has been offered and the resource that has been listed by Dr. Amar, we actually use many of these team that has put together the resources, and Dr. Amar is has been really helpful in putting this vetting through, processing this, and sharing it with us, so that we don't have to reinvent the wheel in a very short time, and that we could just easily use these resources to help community. So when community gets involved in in engaging a crisis like this and no longer are passively sitting by and waiting for someone to come and rescue. It is a win-win situation, because we definitely, if community are prepared, we are no longer the total problem. We are partial solution, and we can even help in mitigating this particular situation. And so one of the things with community's role is also to take a fresh look at how we engage crisis management or crisis mitigation in this particular case. I would say that to take an approach for a decentralized view, decentralized approach. Decentralizing is a better way during this particular pandemic, because we don't have the luxury of organizing response and go to each and every community, because we don't know when restrictions may apply. And because of that, let's be open. Some of you are attending this afternoon, you are heads of organization, you are with NGOs, and you are with different groupings. Consider that we no longer should take the traditional approach of organizing a rescue kind of a mission from our own organization, but rather directly engage our community, those who we are in touch with. So in the next couple of weeks, there will be effective mobilization in our community so that we can reduce the impact of this surge that is presently happening in our nation. So, so that's one of the things that we should consider. So a lot of people are asking, should we stock up things, and where do we send these? Who needs help and all that? If we could talk to everyone and ask everyone to begin to do their part, in their community, this would shorten the time, cut logistics, it will enhance delivery effect, and it should result in a better way in terms of seeing the curve, or rather the chain going upwards trend. So that's the first thing I want to say. The second thing is I want to encourage community leaders this afternoon to consider home preparedness preparation plan seriously, because many of us, we buy insurance for various reasons. I see this as an insurance policy, because we have a system, public health care system in our country, as well as various mechanisms of support. But in this present scenario, we are seeing the trends of this system being overwhelmed. So in that sense, the resources that has been shared, some of these like home care, home self-isolation care during COVID times, all these things need to be taken very seriously, and we should prepare like right now. The action plan is now, don't wait until it's too late. So unfortunately, many times in Malaysia, we have this, we wait and see, but don't. In the case of the COVID situation, we should not, and we advocate for that. Consider your home preparedness plan. And there I list out a few things which actually Dr. Amar has mentioned, as well as perhaps we can address some of these questions as well in the question and answer session. But consider if your house would have allocated room with preference with a bath and toilet that can be used to take care of people who may have COVID-19. Consider ventilation in your house. Dr. Amar talked about simple HEPA filter that is actually very essential. This is part of the new norm. So it is not extravagant, it's not luxurious for you to consider your indoor working environment or your home environment at this time. Think about air quality in this particular environment, because much of our activities moving forward is to provide this safe environment. So HEPA filter is one of the most important mechanism that can trap all these aerosol particulates and things that can reduce the exposure of virus load. Of course, ventilation is also the other part, fresh air coming in. Think about your home in terms of a system of managing waste safely during pandemic. How do you remove waste and sealing of waste? Do you have adequate supplies of personal protection things at home and also personal hygiene? So stocking up, we need to talk to our community. People should begin to stock up some. I would say don't hoard. Just buy adequately enough for 2 weeks supply. And this is the general case. Keep a supply of 2 weeks for each home. Food, vitamins, these are some of the essentials. And then some supplies like non-prescription medicine can be kept at home because when a lot of cases of people who, once they identified positive COVID, they are immediately given a home quarantine order pending availability of place at quarantine center or hospital. And because of that, sometimes there's also limitation of things that they may have at home. So I know of some people who may receive some Panadols from KKM, but that may not be enough. There may be delays of availability of space. So make sure that your household have some of these things to keep you fairly comfortable for self-care pending more help arriving. Every home should have pulse oximeter. And I think when we did this exercise about two months or more ago in Sarawak, one of the doctors purchased a number of pulse oximeters and tested all of them, and pretty much of what is available in the market can perform consistently and be useful enough for most family. So pulse oximeter is a useful thing. It is not a very expensive item to stock up. Consider each home stocking up even oxygen mask, breather mask, and these are some things that we may, if we are exposed to COVID and we are sick and we need oxygen therapy, these masks are personal masks. You don't share this with other members. So each household should provide for some. Let me say also that there are oxygen therapy equipments like tanks and oxygen concentrators. These are very expensive items. Not everyone may be able to have them. So we'll talk about that in the third part of what I'm going to say. I'm going to share. Consider also activities that are healthy that will support your 14-day quarantine for home. So some people have always been so busy with work and whatever other activities that there's no balance in life. So when you are stuck at home for 14 days, it can lead to further anxiety. So have some activities, plan some things that you can do to occupy yourself and keep healthy during this time. Another thing that I encourage communities to do is to have a small little luggage that is packed ready in case you have done your best, your level best. No one can guarantee if we will be COVID-free. And we're talking about even when the pandemic is over, we will graduate to endemic level. So so then if that happens, then you can, you are ready to just go to a quarantine center. So that's something that we can pack and get ready for those things. Another thing that homes can also stock up is currently the saliva COVID-19 test kits. These are a little bit on the more pricey side for most families in Malaysia. But hopefully that the government consider and reducing that price and making it more available so that each home can do periodic tests before being part of the long queue that at government COVID-19 assessment centers. So this is some of the things that we can do, begin to talk to our community, give them these suggestions and guides that they can act upon. Don't wait until it's too late, because some of the resources, they become not available during a panic kind of a situation. We want to avoid, one of the chief aim of having this type of webinars is that we don't have a situation like what India experienced, caught completely off guard, so that we can, engage our communities and get people to start an action plan and do their part, so that we can reduce the impact of what is happening right now. Now, the last thing that I wanted to share this afternoon is for NGOs and various other organizations in a city, please consider pooling resources, coordinating and collaborating with one another, so that we are not duplicating what someone else is doing. I remember during the 2015 flood situation in east coast of Peninsular Malaysia, a lot of NGOs arrived in Kuala Karai the moment it opened up with the same things. We all arrived with mineral water. It would be nice if we can coordinate it so that we can fill in the gap and complement one another. We don't have to compete with everybody because we are trying to do something to help those who are less fortunate. So things that we can pool resources for sharing and even distributing in the community are things like pulse oximeter, oxygen breather mask, oxygen tank regulator, oxygen concentrators. These are things that we can share. Like in Kuching, I know of like 20 organizations that begin to list down, okay, we have how many units, and we can share. We can share to those who may not have access to this. So other things that we can do is consider not just the impact of basic needs during basic physical needs, but consider the emotional and psychological needs of society as we face this huge uncertainty and anxiety that is attacking our nation right now. So one of the things that, of course, there are hotlines available, but we actually began to start conducting simplified trainings to equip community for those who want to help. How can they help meaningfully and effectively, talking with those who are affected, traumatized, or affected badly through this COVID situation. Bear in mind that our nation has a number of children that have lost their parents. And also there are many, many others who have lost family members during this time. So some of these things in our conversation, not realizing what we say sometimes can trigger, because there are serious wounds in the soul of many people in our nation. So skill sets of even having a conversation, being sensitive to those around us will help during these times. And there are a lot of pressures on various segments of society. Sometimes we overreact and even come down hard on certain people. So maybe one of the sad things that I noticed during this COVID thing is that a part of humanity dies in us. So let's remember that no point surviving this if we become inhumane towards one another. We need to be more compassionate and more kind with one another during this time. So NGOs and organization heads that are present this afternoon, or maybe if you're following through the social media or recordings, please consider, let's work together and help all the communities during this time, because it's going to take a collaborative effort And for us to effectively deliver, coordinating is one effective way to do a job for this nation. So that's pretty much what I wanted to share and say this afternoon. So over back to you, Eric.
For sharing how we can do this on a more personal basis or within our respective organizations. All right, now we have some questions. We'll try to get to them. Let me just check the chats. All right, first question we have from parents. Any comments about booster vaccine? And is mixing better? For example, Sinovac 2 doses, then mixed with Pfizer. If yes, what time duration before booster? Amar, would you like to take this? Or
I thought, Liew, you'd like to say that first? I'll mop up.
I think my comment on booster is we need to focus on getting as many people their first and second dose. That is a top priority. Booster comes later. We are discussing that. At the moment, the focus has to be getting as many first and second doses.
Thank you. I fully support that. There are lots of people all over the country who haven't even got their first dose. We must push it to them. There's a second consideration there, which is one other question there about children, and we have to consider that as well as part of the equation. But if I were to boost anybody later, I think that the people we want to consider boosting are those who don't respond well to the vaccine, immunocompromised individuals. Secondly, the frontline healthcare people, the ones who are managing COVID in the ICU, or the ones who are managing COVID in the casualty or in the clinic, I may want to consider them because they're the highest risk for viral load. And if anything, any waning is going to happen, it's going to happen. These people are the highest risk. The other group that we want to consider is those above 60. But I think these questions are too early for us right now as a country. It's something you want to talk after October. Right now, let's get vaccine to the adults who don't have it and then consider children. Eric?
all right, thank you. Thank you for that. Let me get to the next question. Let's see. Yeah, all right. We have a question from Dato Panglima Majastanel. Can anyone here explain why Sabah has the poorest supply of vaccine?
So, well, I suppose got to be careful what we say here, you know. But I think the priority went to some states at that time that we felt the crisis was worse. Take, for example, Labuan. Take, for example, I suppose Klang Valley and Sarawak. You know, but the thing is, now Sabah, it is really at its worst compared to other states, and that the vaccination got to be up here, got to be boosted up here, like what Dr. Amar has mentioned. And I think we have to advocate that. You know, all of us in our own position need to advocate that. And I'm very glad that, you know, Dato Sri, you know, Panglima here, and asking that question.
That's a very important question, and I support what Liew has said. Same answer I've got. I believe right now also, if I can say something that's a bit sensitive, some sultans in certain states have spoken up. And I start to see, for example, Johor vaccination rates going up because vaccine supply has been pushed there because sultans spoke up. So I think we have to speak up. I don't like this. I think it should be given out equitable to everybody who based on need. You know, so it cannot be based on who shouts the loudest. So maybe lobby with the new Minister of Health, but I think it's the people in the administration of the state of Sarawak who need to speak up loudly right now. The rest of us, of course, maybe can write to the media and say we need this and project data that we've been showing to say Sabah is in a bad place. Yeah.
One of the things that, if I might add, is that at the earlier stage, Sabah has very strong anti-vaccine advocates in the community. And for community leaders, I think this is something that we, you know, perhaps when we get more information, then we need to chill on some of these and just promote vaccination and assist registration for communities so that they can get vaccination. So this is something that is quite important because earlier, I think the government showed data of registration in Sabah, registering to get vaccination. And that number is so small, it's embarrassing. So I think we need to work at revising that so that we don't have that situation begin to change. Yeah.
Thank you, Daron. I think that was one of the reasons that they gave according to registration. But can I say the two other tips? Look at what Penang has done. They borrow vaccine from Selangor. I think let's use every mechanism. And Sarawak, they bought some of their own vaccine as well. So I think now is the time for all the rich men in Sarawak, in Sabah. We don't expect any, I tell Perak State, no, don't expect any help coming from outside your state. It's going to be us inside our own state supporting us right now because federal has burned their budget. So, consider whether the wealthier corporate bodies and individuals could actually push for vaccine purchase right now to come to Sabah.
Yeah, I think on that point, we have to learn from Sarawak, how they can up their vaccination rate. Sabah, Sarawak share many similarity. Being one South China Sea away from Peninsula, there are so-called local issues. But then when you look at Sabah and Sarawak, there's no reason why Sabah should not be able to do what Sarawak has done. So perhaps some of you, could share, those of you had the, experience working in Sarawak, what were the key success factors? What were the difference between Sarawak and Sabah that you observe? That should be conveyed to the Sabah community to get our vaccination up.
There's one key word, Liew, leadership. And our kaki was there, Sim was there and running the show. And Sim's got a good brain and he's pushing the whole agenda correctly. He had a very, very good advisory team. I knew the advisory team and they chat with me occasionally. So leadership is key right now to drive it.
All right, thank you. And next question. In the market, there now is a lot of COVID self-test kits. Are these reliable?
Easy to answer this. Go to the Malaysian Device Authority website, MDA website. They list all the ones that MOH has approved. Use those.
All right, thank you. Yeah. Next question. Yes, anything
I'd
else
like to add a point on the saliva test. I think we have to be careful with any test. It's very true, like what the Amar said. Buy the one that has been approved. But we have to evaluate some of these and be careful. No test is 100%. And there will be situations when people have a high suspicion and they get tests initially could be negative. And I really like what Dr. Amar say. Don't assume that just because you get the negative test, you get a vaccine and you are okay. You can start to let your guard down, relax on your SOP. If there's a reason that you suspect yourself and you get a test, you've got to continue the vigilance. We had cases where people have initial negative, later they had the second test is positive. So just a precaution.
Sorry, Liew, can I add that in the Klang, I'm also the Klang Valley task force. I was roped in, unfortunately, but because of Chong is a friend, Deputy DG. So one of the things they made a point during the height of their pandemic, they said, if you have been in contact with someone who's positive and you got symptoms, we assume you're positive, full stop. Test or no test. So I think that's a state that we're coming to in Perak and Sabah and other states. Because we're so widespread, our outbreak right now, if you've been in contact with someone who's positive and you got symptoms of COVID, we should assume you're positive, irregardless of your test outcome.
Right, thank you. And next question, is the COVID virus transmissible by food, parcel, money, stationery, etc.?
Liew?
We emphasize the need for personal hygiene. There are things that we don't know about the virus, but we know it can be highly transmissible. What we do know is airborne is a very real risk, but what we talk about fomites, surfaces, it is a real risk if people are not careful, touching contaminated surfaces, rubbing your eyes. And this is where I really like message from recently from our DG, advocating face shield. The face shield is not just about direct contamination from somebody coughing or somebody breathing into your face. It's protecting your own hands from your hand, protecting your own face and eyes from your own hands. I would say you have to be careful with your hands. So, you touch something, a parcel, you're getting money, you need to wash as soon as you can and wary that don't touch your face until you do so. Dr. Amar, what do you say?
I agree with that. I think if you look at the data, it's plastic that where it lives longest compared to other surfaces. I would never touch my mask. That is the single most dirty thing that you should do. So take care with that. I carry a hand sanitizer everywhere I go all the time, and I will clean my hands the moment I think I can't touch something. When my wife comes back from supermarket, she takes everything to the back, and then she takes off all the wrapping. Those things that are metal or that can be wiped, she'll do an alcohol wipe. Of course, fruit and vegetables, you can't. You just remove the plastic wrapping and wash it with water, and that's about it. I think that's all that we really need to do. If I was in school setting different though, I would wipe the table and the chair that I'm sitting in as a child. I think those are slightly higher risk items. If you've actually got morning class, afternoon class, different children, then I think some of those precautions will be taken. Again, same with the place of work that you are. You may need to take higher precautions there. But airborne, please, ventilation.
Yeah, ventilation.
Thank you. And in conjunction with the question on the airborne, there's a question in how to get a Corsi tube with the MERV 13 filter.
Actually, if I was selling a Corsi tube right now, I'd probably be a millionaire already. No, there are people who have made their own in Malaysia. You can look up the filters on Lazada and Shopee. I've seen them on Lazada. You can buy them directly. So I think just look at the design. I posted just now something on Corsi. I showed a video on how to make it. So there are people who make a box one, there are people who make a single one. The box ones are superior. So it's just a DIY with duct tape. It takes about 20-30 minutes to make one actually. I believe that this is a time for some of the NGOs to make and give away, or make and sell at low cost or at cost, because there are some people who are not going to be able to do this. So we do that. If somebody says, can I use my Corsi and aircon together? Recognize what the aircon does. Aircon recirculates 70% of the air in the room. It's not a safe thing unless you got a HEPA filter in your aircon, or you got a UVC light inside inbuilt aircon, which none of us have got. So that air coming back out is just transmitting these tiny particles back again to other individuals. So no, I wouldn't use that cube with an aircon. I'll turn off my aircon.
Very good point.
I believe that a lot of hospitals now are starting to invest in HEPA filters, even in the wards, to try and clean the air. Liew, any of that happening in your hospital?
Yes, we have installed in some places, and looking at where they are high risk, especially when you're an air-conditioned premise. I'd like to add one point on ventilation, which I think we tend not to mention, is when we are driving or we're in the car. We know that there is a risk if you actually don't ventilate your car. So nowadays the recommendation is to wind down a bit the window, if you can, just to flush out the air. There was a device which you can actually look at CO2 level. We don't all need to buy it. We just use it to test the situation. And we've done that, recently. If we go into our car, wind up all the windows, and if you look at the air conditioning, there is a button where you press, you recirculate the air. That actually is not good. The CO2 starts to climb. If we can, we should try to turn off that and allow ventilation from outside. Or the simplest is just to wind down the window a bit. And I recommend that, especially if you carpool, if you're sitting in somebody else's car, if you take a Grab, and of course, even in your own family, if you can reduce the risk, reduce the risk.
I support what you said. If I'm carpooling, definitely all the windows down. Right now, I have not carpooled anybody. Not even for a nature bird watch. I said, sorry, I'm not ready yet. But can I add one more about the CO2 monitors? A lot of doctors have bought it for their GP clinics because they want to know what's happening to ventilation inside there. And I think this is a device we want to consider for an office or a school, just to monitor what's happening and make sure that we have fixed the ventilation in each of these rooms. I hope there's some engineers in our group and people who can, read more the data on ventilation and advise us how to do it well.
All right, thank you. The question as to whether this is recorded, yes, we have recorded. We will figure out distribution in the coming days on the Sabah Disaster Preparedness Association's Facebook page. We will have a Google Forms link later on where you can use it to stay in touch with us. All right, so let's see, next question. All right, we have a question from Sean Mark. Is it inhumane to reject people who have not taken their vaccination? This is happening now across Malaysia. The most worrying part is that children as young as 12 years old are being asked to take the vaccination. The Education Ministry wants school children to take this vaccination before schools reopen. There have been reports that Pfizer, the only vaccination available for this group, has shown heart inflammation, particularly in male adolescent children. Data from America within 3 months, March to June 2021, 300 children had myocarditis due to receiving their vaccinations. Some doctors say this illness will go away by itself, some do not. What about the children who have not taken it what about children who has it due to taking the vaccination? And it says, will this health issue affect their lifestyle? What is the best option for parents on this matter?
Liew, as a cardiologist, you want to weigh in first?
Yeah, we're hoping that, you're a pediatrician, we're going to start talking.
Okay, let me talk first.
You go first.
Let me say something now. The risk of myocarditis from COVID, if you get it in children and others, is 1 in 3,000. The risk of myocarditis from the vaccine is 1 in 20,000 in children, age 12 to 18, higher if you're a boy, much higher if a boy, much lower if you're a girl. So here's my basic stance for children. I don't want to vaccinate children. If you give me a choice, I don't want to vaccinate adults also. But I think we have no choice right now. We can't win this battle. The vaccination is making a dramatic difference. If you talk to doctors who are working in COVID wards, the person who's vaccinated is pretty good. The person who's not vaccinated goes down very quickly, even if they're younger. So we are seeing a doubling of the children from last year. And we are seeing children who are coming very ill now. My colleagues, my pediatric colleagues in UMMC were talking to me how they're struggling right now with children. So I believe, despite my keenness not to damage children anyway, we will have to vaccinate children once we do adults. Now, the adult death rate is 40 times the children's death rate. So let's finish adults first and then get down to children. Will some children get myocarditis? Yes. I'll leave what happens to them long-term to Liew to say in a moment. Will we have to vaccinate children below 12? Oh, I hope not. But, some countries have opened up after finishing 80% of everybody up to 12 and seem to be doing well. I think Germany in particular. I believe we should work with the vaccine hesitant people. We must not actually treat them differently from the people who are vaccinated. We must support them and live together as a community. I don't think we should treat them any differently. But if a doctor or a teacher doesn't get vaccinated, I think then we pose a risk to the people under our care. Liew?
I have very little to add. And I like your slide when you summarize in the picture, looking at the risk of having complication from COVID-19 versus the risk of the vaccine. And I think that speaks volume. There's no certainty, as you say, but weighing it, that risk of not getting a vaccine and, taking the vaccine, it's very clear. We have to push this, to curb this upstream. Otherwise, the effect of COVID is going to be much, much worse. I have nothing else to add, really. You have said it all.
Could you maybe answer one question that I couldn't answer when people ask me? Okay, today I get myocarditis as a child. The vast majority have recovered. Some have got admitted to ICU overseas and so on. What is going to happen to them long term? Now they seem well. Their cardiac function is recovered. Will they have problems 10, 20, 30 years down the road? What do you think?
Well, we have no answer. We are watching that. People have talked about that there are some late effects. People talk about long haul syndrome. People talk about, whether there will be scar tissues in the lungs or the heart. I think at this moment in time, the key is to reduce the burden of the disease. If we can reduce as many people getting acute COVID, hopefully we don't have to deal with too many chronic COVID.
Yeah.
But we do hear from UK, for instance, they are starting to see a lot of people that have long-term COVID problems. So it's not just about, if I die from an acute illness is one issue. No, people could actually be maimed and can suffer long-term. At this moment, really, we don't have very full understanding. It is a new disease. And again, come back to the point, if we can prevent it, we should prevent it.
So could I add that long COVID affects children? I've been watching the UK data, which is very good. Nobody knows the rate right now. In adults, people are estimating 10 to 30% of infected
Yeah.
people. In children, they're estimating between 1 to 10% of children getting COVID, usually on the higher end of that. And these are children who are talking, Mommy, I can't go back to school, I can't think anymore. Or children who have lost the ability to play or even run across the room because their lungs and hearts are
Brain
damaged.
fog, they talk
brain
about all
fog.
this. Yeah, that's
Yep.
right.
Okay, back to you, Eric.
Thank you. All right, so we have now 2 semi-related questions on this. Why don't we just go from north to south or east to west, do a clean sweep, and would a complete lockdown help?
I want to echo something WHO says. I listen to WHO. I think a lot of sensible people there. They do not believe in lockdown anymore. I also don't believe lockdown. Targeted lockdown, yes. A small area that's got a big problem right now with targeted lockdown. I think what we need to do is work with the community. We haven't adequately worked with our community. We have keep scolding them for failing SOP, but we've got more than 100 SOPs. I don't know which SOP to follow sometimes. So simplify it, make it simple for the community, support the community, give them resources. Some people are poor, they use the same surgical mask for a whole week. I'm frightened with that kind of a behavior. So I think support the community. I don't believe in lockdown. I don't believe in going for a sweep from north to south. We're not going to be able to end COVID this way. I believe let's share out the vaccine, target areas that are the hottest place right now and boost them so that we can reduce the amount of people who die or get long COVID.
Yeah, and just to add, I think lockdown, the word itself is misleading. Yes, we lock down in some way to curb the social distancing, but that itself does not change, the disease pandemic nature. Lockdown should not be passive. It is when we lock down or we have the MCO that we had to start looking at moving forward to the new norm. And that's something that we are continuing to do. And now we emphasize, for instance, the issues on ventilation. We need to look at, for instance, our public places. How is our mall? How is our workplace? Many of us, when we are getting out from the house, where do we go? The kids go to schools. The adult go to work. We've got to look at all these places in terms of what constitutes a new norm. And that's what people need to do. And this is where the community level comes in as well. It's about personal behavior, practice, but it's also looking at environment.
All right, thank you. Let's see. Okay, next question. Selling of vaccines by importers basically reduce vaccine availability to the national vaccination program. Could we ask them not to sell for profit?
Right now, much of the vaccine purchase in the country is Pfizer, AstraZeneca, J&J. I think we're not buying Sinovac anymore. So you could buy that without damaging the national vaccine program. And if people have doubts about Sinovac, look at the Chile data. Chile data is very good for the original, viral strain. But again, Delta, there's still some bit of doubt with Sinovac and Delta, and that's not resolved. So I think we could do that. Can we get the price down? Yeah, I'm sure we can keep the price down if we work together. Sometimes just people trying to make a profit. I have talked to God. I say, curse these people, put them in the darkest of hells, for the people who are trying to make any profit out of the pandemic. I think that's the place for them. Yeah.
All right, next question. Should each household be self-equipped with oxygen concentrator and pulse oximeter?
Pulse oximeter, definitely. Oxygen concentrator, please don't buy one. If you want to buy one, donate it to Eric and Daron and the others, because once we hoard oxygen concentrators, like happened in India, people couldn't get access to them. So some rich people hoard a few because for their family's sake, then the poor cannot. So I think it should be in the hands of hospitals or disaster organizations who can then deploy to people who need. You are coming to the place in the next few weeks when hospitals are going to be having difficulty picking patients up, you and us. So at that time, we will have to support people.
All right. Next question from Running. Patients who are category 4, 5 and recovered from COVID-19, is the damage to the lungs permanent?
Liew?
Okay, I'm not going to claim an expert with COVID. Yes, I do hear from my colleague who treat these, for our infectious disease expert. There are people who have damaged your lung and they can get fibrosis or what we call scarring. It is something real, but I really don't have the exact number for you. But it is true. the more severe the COVID, the higher risk of long-term complications. So getting the vaccine again is important because it does reduce severity. So even though we say the vaccine by nature is to prevent, but you look at it in that context, you can prevent a lot of people getting severe disease. You prevent a lot of these nasty complications. It's not just about death, but fibrosis and all this.
Ministry of Health data that they released a couple of months back, 60% of those who have category 4 and 5 end up with long-term damage and struggle to get
Very
back
high.
to their routine. Yeah.
So it's more than 50%.
All right.
I read about that as well, that people actually are in the following 3 months have a high risk of coming back to hospital, even dying from other complications.
Okay, we are almost out of time. So one last question from Sebastian Chong. He's talking about masking with face shield and double masking and face shield. And I guess the question is, should we consider lobbying to the state government to make it mandatory policy?
If you make it mandatory, Eric, can you make it accessible to people? You see what Singapore has done? They've actually given many masks, I think 5 or 6 rounds of masks. The latest one I just saw, every family gets 5 N95 masks. Wow. Not to mention, the 3-ply masks. So they are poor, they're stateless, they're migrants, the people living on the street. If we don't make it accessible to them, then you go and fine them because you made it mandatory. I think that's unacceptable. I think we must support them before we make it mandatory. And at the same time, some of our leaders flaunt it all the time and get away with it. I think this kind of double standards we don't want to see either. Yeah.
All right, thank you.
Eric, you want to handle some more questions? We don't mind, Liew, would you mind, Liew?
I'm okay.
Yep.
Okay, if everybody doesn't mind.
And people, you're not using Daron. Daron is a guy who held Sarawak together and brought all the NGOs together. You must learn from him. Yes.
I think we're getting a lot of questions that tend to be quite clinical.
Yes.
I'm going to take one more question here, and then I'm going to ask a question to Daron. There's a question here about what is your take on ivermectin as prophylaxis? Everybody's talking about this. I think this drug don't have that conclusive evidence for us to put it into a treatment guideline. Currently, we are actually in process of doing study, both in patients who have COVID, as well as patients who may be at risk of COVID after exposure. So one is for treatment, one study is for what we call prevention. And until we have more of this data, I really have no recommendation. I personally would not recommend it. There is potential risk. Amar?
Yeah, I fully agree. We all look at data. Right now, the data does not support the use of ivermectin for prophylaxis. That means before you get infected, or the early treatment even. That means you just got COVID and you're not getting very ill. There's no data for it. And I think look at this word called Cochrane. The Cochrane reviews are excellent. Also, the FDA in the US and the NHS in the UK both have not approved it. And those are very rigorous organizations. Even our local drug authority has not approved it, except for, off-label sort of experimental use by doctors in studies. That means in research concept.
Okay, I said I'm going to ask the question to Daron. So Daron, the question is, you as an expert with disaster, preparedness and response, what do you think that, as a organization, for Sabah Disaster Preparedness Association, that we could do? Now, this is a new kind of, pandemic. We mentioned a couple of things, and I think people talk about oxygen concentrator. We shouldn't hold it in households, and it should be something, let's say, distributed based on needs. So I'm just some idea I'm thinking about, whether there's something that we can create, like people donate it, create a bank of this, and then it can be distributed if they are prescribed by the clinician, and hopefully when people recover, they don't need to keep it, so it's something not everyone needs to buy, but you can use it. You can either lease it or somehow. Well, I don't know. Are there any other things that that other people are doing in other states?
I'm not completely aware of all the different ones working in different scenarios, but over at least on our side, with the networks that have engaged with us, talking and consulting together, we feel like certain resources are like very strategic. There's a limit to how many oxygen concentrators are available to even one nation. And then hospitals will need it, ICUs may need it, and so we feel like one of those things is also to be aware that some resources should not be hoarded if you're not going to use it. If you have the means, then share the resource and let it be deployed to wherever it may be needed. So not everyone who has COVID-19 will actually need oxygen therapy. So some are very, asymptomatic. So it doesn't get to that stage where they need oxygen therapy. So imagine if everybody wants to buy one out of panic, then our country will be in serious trouble. So that's my thought about that. I think preparing community to share resources, that is one effective way. And also people who use oxygen therapy, they don't use it perpetually forever and ever. The moment your system is showing recovery, you don't want to do that, because you might poison yourself with oxygen, excessive oxygen. So those are some of the things. And then the other thing that we encourage is also the volunteer network of doctors who can do telemedicine to support community when people no longer can be admitted to quarantine center or hospital. There's no place for them. They are at home. So can we do calls? And some of these things we work with various ones like yourself and Dr. Amar and our local doctors, pediatricians who can advise us on that kind of things.
Can I add a comment there that, a lot of doctors have volunteered for that, and it's critical. Not everybody can stay at home when they're infected. Many homes are unsuitable. I often think that in the average, lower income home, if one person is infected, everybody is going to get infected in their home environment. So please think whether there is a need for low cost or free facilities that people can be housed so that they can ride out their quarantine period away from their family, so they reduce the risk. Can I say something about viral load, which is not very well known by the community? Let me take the example of that outbreak that we had in Sarawak, where there was hand, foot, and mouth disease. A lot of children died some years ago, if you remember. I was involved in that outbreak. The first child who gets infected in the kindergarten gets a small dose from his classmate, and he's not too bad. He comes home, he sleeps with his brother or sister, and he breathes on them a lot. They get a very large dose, and they die. So I think the same thing with COVID. The first fellow may not be so bad. Go home, wife, children, other grandpa, grandma, and they get a larger dose of COVID from you because they're in a smaller environment. So sometimes it's good to get the infected person out of the home. But for that, you need the NGOs to get together. I saw just now a link for a COVID hospital, a COVID quarantine facility, but not everybody can afford 2,500. Many people couldn't. So maybe one option is we pay for them to use that facility, or otherwise we help to set up a facility of our own. But you need to think through how, as I said, CREST is one of the organizations that has got a lot of experience setting this up. Daron, you set it up any in Kuching or Sarawak at that time?
No.
Okay.
But we did engage and talk with some groups in the Klang Valley, because I believe that the KKM or MOH have certain criteria to approve the operation of some of these quarantine centers, because it falls under the jurisdiction of this Infectious Disease Act. So while this emergency is going on, we just cannot be doing anything we like.
Yep.
So we advise those who are interested to consult and begin to talk to them, because quarantine care centers for COVID-19 needs to run by certain protocol. So my son is working in one right now. He's with CREST. So this is a situation that is that they are in the Klang Valley is very, very, very dire. Yeah. So yeah, so we followed a few months ago when we had Dr. Amar Singh in our consultation and our webinar. We followed strictly his advice. Do not get COVID-19. By all means, avoid getting COVID-19. So that is a good advice to follow. Shoot for that.
Thanks, Daron.
Yeah.
And we need to find Daron for all his doctors that he's been using, yes. Eric, there's one. Can I grab one question from the side there? What are the risks of those who had 2-dose vaccination with heart disease and diabetes in his 50s? This is the kind of person who needs the vaccine desperately.
Yep.
If you're in the 50s, you got, heart disease and diabetes, you are the one who likely, if you get COVID, to die. That's his reality. Yeah? That's what the data says. So get your vaccination if you get a chance.
All right. To the questions about this video being available on YouTube and other resources, for now, we have everything. We will try to post everything on SDPA's Facebook page. We will post a link in the chat that you can click on. But for now, everything will be on SDPA's Facebook page. All right. Okay, next question. Let's see. My friend, after 2 weeks, confirmed positive COVID and cleared symptoms, wanted to get PCR tests to see if the CT value is above 40 and no risk to people around him. The GP said PCR will show positive and Mycogatra will be red again. So do RTK antigen is enough. And as estimated, the antigen test is negative as the virus load is low and will show negative. This is worrying, though, seeing how can the COVID chain break if all people believe such. CAC doesn't do tests for people without 10 days quarantine. Just advise without symptoms can cut the wristband. How, yeah?
Yeah, well, I think briefly, I think we know the virus may shed, dead particles after recovery phase. And if we test, the PCR could come back positive, but they're not infective. I think, that sort of decision when somebody has reached the day 10 will be assessed individually. There are some patients where they may have what we call a poor immune system, that they may be slower to clear their virus. And some of these, we may have to extend their quarantine and treatment period. But in general, I think what we understand is after day 10, almost all patients are non-infectious and they don't need to be retested. Dr. Amar?
Additionally, it's also an issue of resources. If you keep testing these individuals, we can't test the community as well. This is a limit of how many the Ministry of Health can test. Already you can see the backlog in your own state and also in my state of tests being reported late because they're just waiting for the results to process. So I support what Liew said, yes.
All right, thank you. Next question. Does this damage make patients more susceptible to other lung infections in the future?
Yeah, we'll believe that, any kind of infection that leave, scar tissues in the lung will increase your risk of infection in the future. We see that with other kind of infection as well.
All right. Next question. How long can the vaccine last?
No one can tell you yet. The data seem to suggest that, it does last longer. And I showed you the Israeli data just now. Even though people are saying it's waning, it's not actually waning that much. Again, must remember, not everybody responds. There are going to be people with different immune systems, some people with weaker ones, as Liew said just now, who don't respond very well. And those are the ones you've got to keep an eye out. And if those are the ones, maybe we should give a third dose too. But the rest of us, right now, I believe, past 6 months, your vaccine is going to work, probably 9 to 12 months even. But all this depends on a new variant. If you get a new variant that's resistant to the vaccine, then we're cooked, which is why we need to suppress the spread so that we don't develop a new variant happening. Which is why we mustn't think of Malaysia alone. I often think Africa is the place we're going to get a new variant because nobody has supported them adequately.
Yeah, what goes wrong comes wrong. That's why WHO emphasized that until until everyone, has tackled this problem, no one is safe. New variant could come. Now people talking about Lambda, people talk about COVID-22. These are potential risks, and that's why the sooner we get this control, the better.
Right. There's a comment for those who can't hear me. Apologies for that, but I am having Wi-Fi issues today. So next question, do you think Chinese physicians can help like they do in China?
Difficult to answer that. Huh?
Yeah, well, the Chinese have used a combination of what I understand, some Chinese medicines, herbal medicine. The trouble with these, of course, as we say, in terms of the strength of the evidence, and again, when we clinician, like what Dr. Amar said, we believe in data. We need to see some of this, and at this moment in time, I think we haven't had any sort of review. I haven't come across any systemic review for any of these China herbal products. We do hear about them in the market. There's some capsules that people take and so on. But really, we cannot recommend any of these at this moment in time.
Singapore government has approved one, but it's just basically like the angin you put under your nose, that kind of thing, just to give you some relief of symptoms, but not to treat the illness. Again, if I had 100 of you with COVID right now infected, and I gave you prune juice, 90% of you probably do quite well. And then I would say, hey, prune juice works in 90% of people. No, it doesn't work like that. Okay, it's because that majority of people have a mild illness, but some of us get a very nasty illness, and that's the 10% that we're worried about. So we need proper trials here.
Oh, Eric, we can't hear you.
You're still soft, Eric.
Yeah. Well, there's some
what,
questions there. We can work ourselves up. I suppose you want to.
Liew, you want to take this one? Can a vaccinated person donate blood to a non-vaccinated person?
I was just reading a couple of these. There's which is the one that you're talking about?
Can a vaccinated person donate blood to a non-vaccinated person?
Interesting. I'm not aware if there's any policy about. I think for a person who has recovered from COVID, we don't encourage blood donation. But for vaccinated person, I think it's not an issue.
You probably will give some antibodies and protect the fella as well.
Yeah, that's right. But for people who recovered, I'm not aware. Is that I'm not sure. Got to check it out. Like say recover from infection, whether they can donate blood. I got to check that out.
Tan Swee Lui has got a question there. How do you think COVID will be in the future? Will it come in waves and become endemic? How do you advise hospital preparedness? Swee Lui, nobody knows this. Nobody dares to predict. Last year, some of us did dare predict. Now we dare not anymore because we do not know what is coming in terms of new variants. If no new nasty variants come, if we can vaccinate the whole world to about 80%, then I think it will become like an influenza. Occasionally, some people get sick. We can get back to life, but we will definitely have to change many things that we were doing, especially ventilation, and maybe mask wearing might become a little bit more common. Whenever you're sick, you wear a mask like they do in Japan or South Korea. But nobody can predict right now which way we're going.
Next question about people cutting their own wristbands.
That's
cannot answer. We cannot answer that. That's bad behavior. I think we work together as a community, not just as an individual.
Right. Next question about patients being positive 3 months, and if they land in hospital, should we nurse them in isolation or in a 2 or 3 bedded ward?
This is a very rare individual to be positive for 3 months. The majority of people within 10 to 14 days will have cleared the virus and moved on. We know that some people who are immune compromised might keep the virus longer. We do hear case reports from overseas where people do carry the virus for a longer period, but this is the rare person. We first of all have to know that this person is in this situation. I don't think generally people would know that, unless of course we knew beforehand that he's immune compromised, in which case we may test him. If that is the situation, then we test him, he's still positive, yeah, definitely he will have to be in isolation.
Let's see. Close contacts required to do PCR if no symptoms after 10 days from contact.
I think currently the guidelines recommend that if you have a contact, you should be tested, within the third day, within 3 days, in consideration there can be an incubation. And then, of course, if that test turns out negative, then you could potentially have a false negative initially. So from the public health point of view, you have to maintain quarantine and then to be retested at day 10. And then, of course, depends on the circumstances. If it is an issue of return to work, we're going to look at the probable risk of dispersing the infection, and the public health usually will look at case by case and recommend whether a person can return to work within a certain safety or continue quarantine and repeat a test, potentially a third test. In a healthcare setting, like say a hospital setting, we have had that kind of situation.
Eric, I'm going to jump in. There are two questions which are linked there. One comment saying that they have tested antibodies for Pfizer and still last at 5 months. Another person say, does Pfizer vaccine decline faster than AZ vaccine? First of all, let us say that antibody tests are antibody tests. They may not tell you your immunity. Let's look at hepatitis B, for example. Even though your antibodies disappear, your cellular immunity is still there and can mount a response quite nicely. And a lot of good work by a man called Beasley to show that. So I would say that, yes, it seems that the antibodies for Pfizer drops a bit faster, and AZ tahan lama, to use a good Malay word, lasts a bit longer, but that doesn't mean very much. We don't know what the real cellular immunity, and we may discover that in the next couple of months, which way we are going. So don't trust the antibodies per se as a marker of how well protected you are.
Bedridden elderly at home, is it advisable to be vaccinated? If yes, is there any arrangement for home vaccination?
I can't speak for Sabah, but I know that in Perak, we have already done all our home bedridden ones. Our state pengarah is very proactive. If somebody is extremely old and fragile, you're thinking that they might die in the next 1 or 2 months, maybe you want to rethink the vaccination. Okay, but if people are at home, they're fairly well otherwise, they're just stuck at home because they're physically disabled, I think you want to vaccinate them. I hope Sabah has got a home vaccination program. Liew, you know of any home vaccination?
I'm not aware.
Okay.
Yeah, we've got to ask our public health whether there's such a program.
For Sarawak, they are doing that for cases of people who are invalid, or they're not able to travel, or they are wheelchair bound. The special arrangement is made for them to get vaccinated at home, but there is a long wait. So you may not get it as fast as you prefer. So this is some of the logistic problem that they have.
But that's something to look into. I do know that there are, nursing homes, that have had that sort of arrangement made. But I'm not sure whether that's an initiative or is something which is systemically done. I need to check on that one. But that would be something important, like what we mentioned. They are high risk. There's a question about a person having sore throat for already 2 days, and the third day started to cough. What is the chance that it's a COVID or just a flu? How urgent is the COVID test? I think with the current surge, whenever somebody has symptoms of upper respiratory tract infection, what we call an influenza-like illness, including a sore throat, including a cough, including a runny nose, a fever, you have to suspect COVID-19 until proven otherwise. You need to get tested as soon as possible. You need to take the precaution to protect spreading the infection to your family, to your household. That's the best advice I could give you. I know that there are parents who say that, look, it's just a flu, you know, they just look after the kids. And let me tell you, I've had my own staff turn out to be positive because of that. Don't delay, get tested, contain infection.
I would support what Liew said fully. Right now in the outbreak, assume if you got symptoms of COVID, that is COVID. And I would say that the majority of people who have COVID don't know they had COVID.
All right, thank you for the advice. I have a DM question here from Liew. Germany put a halt to vaccination for 2 weeks. My wife and friend's body became very weak and lost strength after vaccination. Please advise.
You know, some of us are going to respond differently to the vaccination. After my first dose of Pfizer, my blood pressure shot up. I'm usually very low blood pressure, shot up immediately. I had chest pain, angina, and then it settled. Then I had very severe arm, could hardly move my arm. And then a few days later, I developed arthritis in one joint. Now I'm very peculiar. I react badly to anything. I knew this was coming my way because I react badly to drugs, and that's been my history. In fact, I was vaccinated in the hospital because I have a higher risk of dying from allergic reactions as well. So each of us can respond differently. And so some of us are going to feel a lot of side effects for a period of time. But I think if it persists, you better see a doctor to find out whether there's something else that happened at the same time.
Okay.
There's a very important question here about that in Sabah, we have a lot of unregistered migrants, and are they entitled to get vaccine under the National Immunization Program? The answer to that is yes. And it will be a continuous issue if those populations are not covered. True. The virus does not differentiate your nationality. And for us to achieve total population protection, we need to vaccinate as many.
If you don't vaccinate all the people in your community who deserve vaccination, you're going to damage everybody else. That's the basic thing.
Yep.
All right, we have a question on identifying vaccine non-responders, and it's clarified vaccine non-responders are generally those who turn up negative in antibody tests.
Yeah, but you know, to do an antibody test for everybody is very expensive and prohibitive. Better spend the money on buying more vaccines. I think that's how most people look at, or controlling the pandemic in the community by doing more testing.
All right, so we have a hypothetical one here. Say a child of 7 years old has contracted COVID after visiting GP due to diarrhea. What should the parents do next? There's a suggestion there that he got the COVID from the GP, huh? I'm not sure about that, okay? But right now, anybody, I limit my visits to hospital. In fact, I put off my cardiac appointments with IDRN and talk to my cardiologist on the phone and give him, an update on my condition and just get my drugs from him. So I think avoid, unless you got a medical problem that needs attention, then you go. So this 7-year-old, okay, lots of people have called me up what to do. My child is infected. First thing I tell the parents is wear a mask for yourself. If your child can wear a mask, good. Otherwise, you wear a mask. Now, it's very difficult to isolate a child from the rest of the family because you need one. So I would say one family member be with the child and isolate from the rest of the family member, stay in a room and the rest of the family member keep away for that person. So it's very likely the other family member, that parent, mother or father, is going to get infected as well. And I probably will do an RTK antigen test for them periodically, 3, maybe 7 day, into the illness of the child. The rest of it is just watching the child. I would get a pulse oximeter. I would measure the child's pulse oximeter 3-4 times a day and keep an eye. We're good to get a doctor who can actually do a tele, as Daron was saying earlier, do a video call with me once or twice a day and just see how the child is doing, look at them, see their breathing pattern and stuff like that. The majority of children are going to do well. Only a minority are going to run the trouble, and you need to pick up those who run the trouble and bring them to hospital. If we had all the facilities in health, I would put this child in hospital, but we don't have that kind of facilities anymore. So it would have to be a home quarantine situation. Yeah. We also have a question on the risk of reinfection and the incidence of reinfection in Malaysia.
I came across 1 or 2 reports on that, isn't it? Suspicious reinfection from somebody who has recovered. I haven't come across many literature since then. Have you come across that, Dr. Amar?
There is a database online that people keep for verified reinfection. That means you had a confirmed infection, you cleared completely, and then you got reinfection. You're not somebody who kept the virus for a longer period of time. But the numbers are very tiny compared to the rest of the population. But it is possible to happen. I also believe that it could happen again if you get another variant. It's very likely.
Yeah.
As well.
The variant, and of course, usually you recover long after when your antibodies no longer have that protection in the initial few months.
All right.
There's
Next
a question here.
16-year-old, is it? The 16-year-old safe to receive vaccination. Yep.
Let me tell a story about this. I had a call from one of my colleagues, Paediatrician from another state, and she said, hey, my private hospital is offering me vaccine for my children. Should I take? And she had 3 children, a 17-year-old girl, a 16-year-old boy, and a 15-year-old girl, 3 children. So we discussed the risks of Pfizer myocarditis, which what she had been offered. And she decided that she was going to go ahead and vaccinate her 2 girls, but she's going to wait on a boy to get maybe a Sinovac vaccine or maybe a Novavax vaccine later. So that's the decision she made. Again, it's a very personalized decision that individuals should make. So if I had a chance to vaccinate my children, and some of the doctors are getting offers for getting vaccination from their private hospitals, I think many of them are taking up the offer and vaccinating their children. But you must be aware of the risks. I believe that, as we talked earlier, by October, we will start offering this routinely to children in the whole country. At that time, parents will have to decide. Again, Liew, I'm hoping that we will get a slightly safer vaccine than Pfizer. But even if it's just Pfizer, I would be the one first in line to say, let's do it, because the risk of COVID is so much more severe for that child. Remember that once we vaccinate adults, COVID shifts down to the non-vaccinated people. This is seen in many countries where they vaccinated their adults, then the children get the COVID after that, like the US is facing right now.
Yep.
All right. For those who have questions, please enter them into the chat, because we have a few hundred people here. So having speakers come on would be a bit unfair.
Yeah, I think we might have missed one or two, just scrolling up, down, and
try
just
to
check
the question.
Yeah.
All right. One question we have is about the UK, where they wear masks outdoors but not indoors. I already know Amar's view on this.
I think that's a mistake on the UK part, and many of the UK doctors also think it's a mistake. I've been trying to tell the government, but the government also trying to stay in power and give liberties to their people. Also, you must remember the UK is far higher vaccination rates than us. So that's why they removed some of these restrictions. So you look at Israel, they reinstituted mask mandates all over the place. So right now, let's not follow that. We're watching UK very closely to see what's happening with them. They've gone over their football games and people are getting infected there. Keep your mask. I think it's your safety gear right now.
Hey, another question from Michael. My staff has taken 2 vaccine doses. He showed symptoms of cough on Thursday and did self-test and shown positive, and did PCR on Friday, and the result showed negative.
Okay, I would say if you have symptoms, like what Dr. Amar say, you have infection until proven otherwise. And we all know that initially you can have a false negative test. You have to take the precaution, you have to behave like you are infected, and of course, you have to have a retest.
Fully agree.
Thank you. And there's a question here. What do you think of expirating when injecting the vaccine?
Expirating.
It means,
I think, is it pulling back the syringe?
Yep.
I think that's something quite routine, that when we do an injection, when we put the needle into, the injection site, a gentle negative pressure, just in case that we are in the vessel, we don't inject into the blood vessel, and then we inject the vaccine into the muscle. That's something fairly routine, I would say.
We can't hear you, Eric. You're muted.
Yeah.
Sorry, but is there any risk of lung scarring for category 1 and 2 patients?
I think the risk is very low. There are long COVID cases in people in category 1 and 2. as well. Okay, but that risk is very, very small compared to the risk of people in 3, 4, and 5, especially 4 and 5. But we cannot say it's zero. Okay.
I think a more important question now is for those who initially have category 1 and 2 disease, you have the risk of deteriorating. And that's something we're starting to see. We don't know whether something, is it because like Delta variant is more aggressive? So I think, we have to be careful and say that, you got category 1 and 2, you're okay, you go home, you'll be fine. The worry is people deteriorate not knowing. And this we talk about the happy hypoxia. Why we're advocating to monitor oxygen at home is because people don't feel breathless until the oxygen become too low. So just because initially say category 1 and 2 and being told you can go home, you don't need to come into the hospital, don't let your guard down. Still got to be careful. Still have to check.
All right, we've gone on for a good 2 hours here, so we're going to start wrapping up.
It's 5 o'clock, yeah. Got another one at 5:30. Forgot to wrap
All
up.
right.
Otherwise,
Okay, just one
continue.
last question. Is Sinovac available for walk-in and which PPV? Does anybody know?
For currently, a message from our State Health Director is people are encouraged to go to any of the vaccine center. Walk-in is now encouraged. Now, of course, be careful. Please observe the SOP, the crowd, don't get infected. But otherwise, you can walk in to get vaccination. Now, of course, at this moment in time in Malaysia, we don't give people choice of what vaccine. A vaccine, any vaccine that has been approved in Malaysia at the moment is a good vaccine in some way.
All right, thank you, everybody. Closing thoughts from our speakers, starting with Daron.
Well, I think that there's a lot of interest shown and concern by judging from the questions. People are concerned about what is developing, and I think awareness is one good start, but we encourage the public to take responsibility and begin to mobilize some kind of preparation so that you can lower the impact of current surge. And I think that will help everybody. It's a win-win situation. So that's my comment.
Dr. Liew?
As we said, the take-home message, number one, the surge is getting worse in Sabah particularly. I'm very concerned because the projection, from, some, have said that we might hit the, peak, in September. And I think Dr. Amar also warned us, even if we get our vaccine out quick, we still have that 2 weeks of, time for the antibody to mount. So we are looking at within the next 1 or 2 months, to have more disease. So I would advise everyone, it's not just about COVID, looking after yourself. I sent a message out to many people before. It's not just COVID. This is a time to stay healthy. This is a time to stay out of trouble. Don't fall, don't get a heart attack, don't get a stroke if you can. Avoid an infection. You're diabetic, don't go barefoot. No, this is not a time to get to the hospital. Basically, just be careful. Thank you. Vaccine, strongly recommended.
And Dr. Amar?
I saw a quick question there, about how many people who are going to get ill. And at the best of times, 8% of people got worse, got severe illness. That's MOH data from last year. Okay, so that'll give you a ballpark figure. This time it's going to be higher. Maybe you think about 10% of people. So 1 in 10 people who get COVID is going to go and get unwell and require hospitalization. So don't get COVID. As Daron said earlier, my main message quite often is don't get COVID. Do all the protective measures to prevent yourself from getting COVID. Secondly, educate yourself. It's a time not just to listen to us, but read. Don't just look at the WhatsApp message, which are just floating around. Look at the hard data and learn how to read it for yourself and think through. And thirdly, support your community, please. I think we need to work together to overcome this. We're not going to get past this individually. And please remember the poor and the stateless. This is a time they really need our support.
All right, thank you. Thank you so much, everybody. Thank you to our speakers. Thank you to the SDPA support team who've been working so hard behind the scenes to get this seminar running. If you check the chat now, we have posted a link to SDPA's Facebook page. So please use that to stay in touch with us. We will be also posting a Google form link where you can just tell us your contact, and we will use that to keep in touch with you when we organize events in the future. So thank you so much, everybody, for joining us. We have had hundreds of people joining us today, and thank you so much for helping get the word out. So stay safe, everybody, and like Dr. Amar says, don't get COVID, and we will see you next time. Thank you, everyone.